Hello and welcome to the third learning objective for this module. So for here, we are going to discuss managed care and we're going to look at some of the cost control strategies that's been used within managed care organizations and also look at in terms of why there's been some struggle with meeting those cost control objectives. So we're going to talk about the number of cost control strategies. I'm going to go talk about as many of them as possible, but also have a little bit of explanation for some of them, go into a little bit in depth in explaining what those mean. So we're going to start with utilization management. So the idea of it, and I've talked about this so many times in this module already, is that it's to ensure that there is the medical services that are provided by providers are necessary before they are approved. And this is where prior authorization comes in. But besides prior authorization, you also have step therapy and you also have medical necessity reviews. So we're going to take a very short period to talk about step therapy and medical necessity reviews so that you understand what that means in the concept of managed care. So, like I said, also the whole idea of this utilization management is that it helps prevent overuse of expensive procedures and medications. And then another cost control strategy that is used by managed care is capitation model. I've already talked about this before when we mentioned the per member per method. Per member per month fixed payment that goes to providers. So same as the utilization management strategy is to encourage cost effectiveness in terms of care because providers have they know they get a flat fee for each enrollee that uses the service, that there's a push for more preventive care rather than the more extensive or more expensive curative treatments. So providers are kind of incentivized to focus a lot on preventive care since it's cheaper, and so that in this way they don't have to face the financial risk that they would have if they gave more expensive or more extensive services, and insurance company refuses to reimburse it because they said it's out of budget for them. Another strategy is the provider network restriction. I talked about this when we talked about the different types of managed care organizations and also different types of managed care plans, where we have providers being signed to be in network, and for providers that are in network and patients use those services that are in network for them, their out of pocket payment is lower. However, for providers that are out of network, when patients use that, they would either have to pay a higher out of pocket cost, or the insurance company may not cover that service at all. So this is some of the restrictions that are used to kind of limit patient choice, but so that in this way they kind of have to use those that are within network that the managed care organizations have been able to negotiate a good fee in terms of services that they cover. So, with those who are in network, the managed care organizations, like I said, have negotiated discounts with their preferred providers so that patients can use the services at a reduced cost. The other strategy that is used is the value-based payments models. What happens with this is a little different from all the other methods that we've talked about. So with this, providers are rewarded based off of quality of care and patient outcome. And it uses tools like pay for performance and bundled payment. So the idea is that, providers are being encouraged to use effective value-based treatment for their providing services. So I'm not really going to go in depth with with this strategy, because we talk a lot about it with the PHM 6130. There's a whole module that really breaks this down, talking about the P4P and bundled payments. So if you are taking PHM 6130, you're going to encounter these concepts in it. Or if you haven't already taken it, then you're going to encounter it by the time you take that course. But just to let you know, the reason I'm not going in depth with it is because we kind of covered it in that other course. The other strategy that is used by managed care organizations is the tiered formularies for prescription drugs. I talked about this. I talked about formularies, not so much the tiered formularies, but I'm going to explain in terms of formularies being tiered. So with this, what happens is that the pharmacy benefit managers have medications that are divided into tiers based off on cost effectiveness. The lower tier is where you have generic medications there, and the higher tier you have the brand names, and then you have the specialty drugs. So the generics have the least copay, the higher ones have a bit more higher, and then specialty has even higher copay. So this idea of it being tiered is that it encourages patients to use those generic ones that have lower copays. And then we have case management and care coordination. What happens with this strategy is that high risk patients get personalized health care, which is all geared towards reducing hospital readmission and emergency care visits, and also works very hand in hand with improving chronic disease management. I'm going to talk about this in a bit more details. With you guys being population health management students, you may end up working in this capacity with a managed care organization and having to be in charge of maybe a disease area. And so that you need to have a little bit of understanding about how this works. So another strategy is a disease management program, which works hand in hand with the case management and care coordination. So this focuses on preventing complications that come with chronic conditions, like type 2 diabetes and stuff. Part of it includes education, including self-management, lifestyle counseling, and also remote monitoring, just to make sure, let's just for example, type 2 diabetes, that their blood glucose reading stays stable, and they're able to remain stable, and they're adhering to the drugs that they're being required to take. So because you are if this is being done properly, there will be less stress on the healthcare system in terms of use of healthcare services, but also cost of using running the healthcare system, because there will be fewer hospitalization and fewer readmissions and fewer emergency visits. So this whole idea is for it. Then the other strategy, which this is the last strategy I'm going to talk about for this module, is the use of telemedicine and digital health. So, and a lot this has happened with pushing telemedicine and towards the remote areas, not just remote areas, but it really works for people who don't necessarily get time off, paid time off, and which that in order to meet your hospital visits, you may have to take time off for which you're not going to be paid for, and then the time to drive to the hospital and then drive back and all of that. So telemedicine has really helped with remote care and made it such that in-person visits become what is necessary, because you're paid the amount of money that in terms of co-payment is lower in person versus telemedicine. So this also, just like this is management program, does help reduce ER visits and hospitalizations because you have this very good way of communicating with your care providers. If you're suspecting that something is a bit off with you, you can just send them a text message and then they'll reply. And it has, I think my chart, for instance, has a way that you can actually take pictures of places where you're kind of suspecting something may be off, and then send it as a message, and then your clinician will look at it and then get back to you. And if there's a need, they could tell you to just come in. So it does help reduce ER visits, and it does help reduce care, follow-up care and medication adherence, because you're able to quickly get in touch with your provider to say, okay, I think I'm not feeling too good with this, and they're able to converse with you better. So, like I said, I was going to talk a little bit about case management and care coordination, since some of you may go on to work for managed care organizations, and you may be in charge of, having to manage, let's use, for example, type 2 diabetes for a population. So you kind of want to have a little bit of an idea of how that, goes. So case management is a structured approach where you have nurses or case managers that are more or less like assigned to high risk patients, with the idea being to assist them in navigating the healthcare system. Like I mentioned in previous modules, the US healthcare system is quite complicated, and in a situation where people have quite very low health literacy, just low literacy, and then combined with low health literacy, it's very, very difficult for most patients to navigate the US healthcare system. So this is where case managers come in, particularly in chronic conditions where they're even having to interact with the healthcare system much more than regular people. And so if it's more complicated for them, it's going to worsen their health outcomes. So this is where case managers come in. So with care coordination, you have a team of people who are working with patients, a group of patients that is related towards managing their diseases, especially in chronic conditions. They generally more than one clinician that is, working with the patients. Like for example, you have in diabetes a couple of specialists that are working with them. You have the dietitian. We also have the nephrologist, I think that's what it's called. And then there are a couple of people that I think those who take care of the feet are also part of the clinicians that are there. So, and all of these different specialists have to find a way to communicate with each other and to communicate with the patient. So this is where care coordination comes in, because you then have the case managers helping to communicate with all of the specialists and also having to communicate with the patients. So, how does care coordination and case management work in managed care? So, it begins with data analytics, where the managed care organizations have all the data that come with people being enrolled and all the data that come with healthcare utilizations and EHRs that allows them to track patients with chronic conditions, or seeing who is experiencing frequent hospitalization or who is being reported as having medication non-adherence. So these patients who, high risk patients, then receive customized treatment plans that, covers many things, including their medication, self-management, lifestyle change, follow-up visits. And then the case managers then help smooth the communication that is happening between all the specialists that is in their care, with the care coordination, as well as the patient, so that everybody hopefully is speaking the same language and everybody is on the same page about everything. So, case management and care coordination really focuses on preventive care, remote monitoring, self management education, with the goal being to reduce ER visits and hospital readmissions. So, it kind of makes it for those who have chronic conditions to be able to manage their diseases better, so that they have less need for emergency visits or being readmitted to hospitals. So case management and care coordination approaches are used in disease management, for which I've already kind of intimated you guys of. So That out of the way, let's talk about some of the utilization management strategies. We've already talked about prior authorization. So I'm going to basically focus on medical necessity reviews, step and step therapy. So with medical necessity reviews, is this is a process where insurance evaluates whether a treatment procedure is necessary. So it's more than prior authorization, because prior authorization, as we have discussed it yet, just focuses on before treatment. With medical necessity review, it goes a bit further than that. So the goal of these reviews is to make sure that only the services that are appropriate and evidence based are the ones that are covered. So there are different types of these reviews. You have the prospective review. This is where prior authorization comes in because it happens before treatment is done. And then you have the concurrent review. This happens during the treatment. Treatment has already started, and insurance is, insurers are going through an ongoing evaluation to determine, okay, is there still a need for hospital stay? Should treatment still continue, and stuff like that. And then you have the retrospective review. In this case, treatment has already been concluded, patient has gone home, and stuff like that. And then claim is sent into the insurance company, and they look at the claim, and in order to determine whether the treatment that has already been provided was, necessary, whether it met the medical necessity criteria that they have. So then with step therapy is also called fail fast therapy. With this, what it requires is that patients have to first show that the lower cost treatment or the lower cost uh, medication that was covered by the insurance did not work. And if it doesn't work, and now they need a more expensive treatment or a more expensive medication, then the insurance company then have to determine whether they would cover that as well. But the first level has to be shown that it didn't work before a decision is made about what happens the next one. So this usually happens with brand name medication, especially specialty medications and biologists. I've included a link here in case you want to know more about what biologists are and how it works in some disease areas. So, just like medical necessity reviews and prior authorization, the whole idea of it is towards cost effectiveness and trying to prioritize lower cost alternative. So, how step therapy works is that first one, patients need to have tried the lower cost medication or lower cost treatments. And then when that doesn't work, it has to have shown that it was ineffective or it caused the kind of side effect that was not manageable. The provider can then request for approval for the patient to move to the next tier medication or the next tier treatment. So only after the insurance company has, determined or approved the fact that yes, lower tier medication did indeed fail, then they can, make the decision on whether to approve for the higher cost treatment or not. Then we have the tiered formularies. I mentioned it earlier, but we'll just kind of talk about it a bit more here. So I talked about how formularies have a list, or is like a list of covered medications that insurance benefit managers have to determine, what is the out of cost payment for patients, or whether a medication is covered or not. With the tiered formularies, it's like this list is kind of put into different tiers. So why are tiered medications used? The idea being, just like all the other strategies, is to reduce the costs to patients as well as insurance company, and also trying to encourage cost effectiveness. So how it works is that the lower tier, which is usually where the generic drugs are, and have the lowest co-payment, like I mentioned before. The tier two is where you have the preferred brand name drugs. They have a more moderate co-payment. Tier three is your non-preferred brand name drugs. They have a higher copay than the preferred brand name drugs. And then the last tier, or the specialty tier, is where you have the high cost specialty medications, usually for very complex conditions. So this, I've included this bit of a explanation to what I mean by preferred brand name, non-preferred brand name, and specialty medication, so that you can understand how they differ from each other. So, why has there been challenges to cost control within managed care? Firstly, is that healthcare costs is rising everywhere in the world. Some of it is caused by inflation that happens with the economy. A lot of it is also caused by the way diseases have been changing, and all the risks that come with travels and migration. But it's just, and also you have a lot of technological advancements that has been made in the world of medicine. So while managed care has numerous methods that's been used to reduce unnecessary spending, there are a lot of challenges. So some of the challenges is from the patient side of it. An example would be patients being dissatisfied with the restricted network and prior authorization. With restricted network, when we talked about the anthropological values of the US, where we talked about individualism, this is where it comes into play with the dissatisfaction with the restricted networks. And then from the provider end of it, there's a lot of pushback because of the financial risk that is shifted to them due to PMPM, and also some care organizations, some managed care plans have lower reimbursement. An example would be Medicaid. Medicaid managed care generally has lower reimbursement, so and that's why you don't have a lot of providers who are part of their in network service. And then the time that goes into processing claims, getting the pre-approval and all the documentation that it requires to report and stuff, it adds up, not just time, administrative time, but also expenses. So that is one of the challenges that is. But this is more or less like a general challenge. I want to talk about some specific challenges that comes with some of the particularly the utilization management side of the cost control. Some of the challenges that has been done for, noted for medical necessity reviews is that the patients, there's a lot of delays, especially whether it's prospective, whether it's concurrent, or whether, especially prospective and concurrent reviews can take time, which delay the time that patients get to get services. And then this particularly happens with retrospective, is where patient has already received services and then is denied, and then they have to pay the cost of it. But whether it is prospective, concurrent, or retrospective, there is still risk of treatment being denied, even though it is needed. And then you have insurance and providers disagreeing. And in this case, insurance tend to have all the power in that means, because they have the money. So you could go into appealing a denial, but that's time that goes into patient either not receiving care or not being able to move to the next level of care. And this is very frustrating for providers who having to either provide additional paperwork or having to justify the reason why they are recommending a treatment or medication for their patients. So with the step therapy, there's also delays very similar to the necessity reviews, with higher tier medication, also administrative burdens, where there's a appeal, and while trying to get approval to move to the next step, patients may be experiencing side effects that may be worsening their health outcomes or staying on an ineffective treatment that is not really doing anything for them. So with the tiered formularies, you have higher costs for patients needing medication, specialty medications. The cost, out of pocket cost, is very high. And if they are waiting for prior authorization, that could also take a lot of time. So you can see a situation whereby if you get prior authorization, the cost may be lower for you. But while you're waiting for the prior authorization, you may be asked to pay for the full price, which wouldn't quite work. I'm going to use an example of what happened to me. It's not really tiered formularies, but that will just kind of give you an idea of what happens. So I have melasma, which is a skin condition. So I was being treated on one medication, and then my dermatologist decided, that we needed to add tretinoin to it since the medication I was being treated on was not working. However, tretinoin is not covered for melasma. Under the tiered formularies, is covered only as a treatment for acne, but not for melasma. So when it was prescribed to me, and I went to get it from Walgreens, I was told that it was not approved. I could either wait for prior authorization or buy it, pay the out of pocket payment. Now, if it had been covered, I would have only had to pay $30. Without coverage or without waiting for prior authorization, the cost to me was $600. And so I went back to my dermatologist and said, this is what I was told. And he said, it's very unlikely that it's going to be authorized. So I should either pay the 600 or we'll just do away with it altogether. So I could not pay 600 for it. So we ended up not adding it to my treatment, which means that I'm still having to go through the skin condition because it's taking a lot longer to get done. So just to give you an idea of what happens with the tiered formularies. There's also a lot of confusion for patients about medication coverage. Like I said, the PMBs are not very transparent. So a lot of the times patients don't know how much it is that the cost for them is until you get to the pharmacy, and then they tell you this is how much you're supposed to pay out of pocket, which can be quite jarring, and sometimes you don't have that amount of money saved. So, why has cost control been difficult under managed care? So, I've talked about this in several slides. So, I'm just going to mention it here with the provider and consumer pushback, and also some of the challenges that come with prior authorization and utilization review issues. I don't want to go over it again since I've talked about it extensively. Other things that is happening with that is the rising cost of prescription medication, and also so with that you have high cost medications, especially for biologics. That is quite difficult for in under managed care, because a lot of them are innovations that are coming, and also experimental medications. So it's not something that managed care has been able to do a great job of. And then you have the PMBs not not passing along the information about discounts that have been negotiated, and patterns, having a problem, or, causing a challenge with competition with drugs, because of with patent protections. Pharmaceutical companies get like 20 years protection to manufacture and sell drugs exclusively within the period that the patent is active. Generic manufacturers cannot apply to make the same drugs at a lower version, which then limits competition. So if it's as if the only drug on the market for some medication, for some treatments, are just those brand names, and they have a higher copay for patients. So that's it brings a challenge. And then we've already talked about merger and acquisition that's happening within the US healthcare system, which also works very here with managed care. And this is bringing all the problems that I talked about before, limiting control, that's, competition, which then pushes costs towards patients, and then patients in rural areas are underserved, regions having fewer access to in terms of services that they receive. So, and then you have the patient cost sharing burden coming with high deductible plans. While it has lower copayment, it also has much higher out of pocket payments. And I mentioned how Medicaid plans generally have lower reimbursement, but also in addition to that, it offers fewer